I'm here in Chicago at ASCO, and I just had the pleasure of doing the educational session on relapsed and refractory Hodgkin lymphoma. And during that session, I talked about salvage regimens that we use in the second-line setting for Hodgkin lymphoma. And in general, the standard approach for a patient who has relapse or refractory disease after their frontline treatment for Hodgkin lymphoma is to give some type of second-line therapy, followed by consolidation with an autologous stem cell transplant. And the choice of treatment really is different depending upon which institution you go to. And in general, the older regimens or the more traditional combination therapies, we do think of them as fairly similar. They include ICE chemotherapy or DHAP or gemcitabine-based regimens. Now that we have newer regimens for Hodgkin lymphoma, such as rituximab and now even more recently the checkpoint inhibitors or PD-1 blockade, we're using some of these regimens in the second-line therapy as well. And there is pretty mature data now with the incorporation of rituximab, both using it either as a single agent, potentially sequentially with chemotherapy for patients who don't become PET negative after brentuximab, and then followed by autologous stem cell transplant, or in combination with other agents. So brentuximab has been looked at in combination with bendamustine as well as combination chemotherapy, and then even more recently it's been looked at in combination with nivolumab. And what I mentioned at my talk was that one of the as far as the novel regimens are concerned, if I have a patient who is not going to go on a clinical trial, the regimen that the regimen that's my regimen of choice right now is brentuximab plus nivolumab, and that's because that regimen in the phase 2 study was very well tolerated. The complete response rate was about 61%, which was very encouraging given that we see much lower complete response rates with either one of those drugs alone. And patients received a total of 4 cycles of treatment and then were consolidated with autologous stem cell transplant. And we have pretty good durable, we have some durability, evidence of durability of that regimen now, with follow-up at about 21 months. About 82% of those patients are progression-free. And so if I can get those drugs, so neither one of them are actually FDA approved in the second-line setting, but if I can get those drugs, I do like to use that as a second-line approach. I did talk about a lot of investigational approaches that are now being looked at in the second-line setting, and many of those are now using the PD-1 blockade. And for example, we have a study looking at pembrolizumab followed by radiation therapy without transplant, and this is particularly for patients who are very favorable when they relapse, and so they have to have early stage disease and they have to be eligible for radiation, and they can't have B symptoms, and so it's a very select group that is eligible for that study. And then there's many studies looking at checkpoint inhibitors either in combination with chemotherapy or given sequentially with chemotherapy, and all those studies are ongoing, and all of those are meant to use as a second-line therapy followed by autologous stem cell transplant. So a lot of potential changes are going to be occurring, a lot of studies that are ongoing, and hopefully we'll learn quite a lot from them.